Okay, we're going to demonstrate the STS mid-leg casting sock, which is used for most AFO braces, including all of our gauntlets and the California AFO. We're going to use the mid-leg version. There is a longer version called the Bermuda sock, which is used for the solid AFO. The mid-leg STS sock you can use for just about any Ritchie brace or any AFO other than the full-leg solid AFO. So the process begins with applying a plastic strip right over the top of the leg and the foot. And the landmarks are second metatarsal and right up the shaft of the tibia. This edge here is placed just proximal to the second metatarsophalangeal joint so that there can be flexion of the toe without digging into the strip. So we're going to place the strip just about at the surgical neck of the second metatarsal, and we're going to hold it right here, and we're going to secure it with paper tape and use about 3 strips of paper tape. And it's good to have these cut ahead of time. Next, we're going to place a plastic tube which is going to create a cutting channel for the STS sock. Now we're going to place this on top, and often it's helpful to have your patient hold that in place because it can be a little tricky getting everything lined up on this. Notice I put this paper tape in a different spot than the tape holding the strip. That way you'll see later when we pull this tube out, we don't pull the strip out. So we don't overlap the tape, we put it in a slightly different location. And we're going to bring one more down to here. So we have cutting channel tube, and then below that is the strip to protect the leg when we cut this off. The final step in the preparation is application of the plastic bag. This is essential to prevent the casting sock from damaging or sticking to the skin. And we'll pull this onto the foot and leg and get all the slack out of it. So we've got everything in place. So what's really important here is that we get the patient positioned properly. You want to get that foot so that it's about chest high, so that it's relatively effortless to lift the foot, suspend the foot, and position it in subtalar neutral. You want to be able to have your elbow bent in a comfortable position so you can load the mid-tarsal joint. So you get your table adjusted just about like I do so that everything is comfortable for you and the patient. It's essential that you wear gloves when we cast with this particular material. It's pretty caustic to the skin, so you have to wear gloves, and the patient has to have a sock on or a plastic bag. We're going to use the size small STS mid-leg casting sock. This is a woman's size 8 foot, so the size small is appropriate here. These are pre-packaged. They have a pretty long shelf life because they have an inner wrapper that you're going to have to undo before you dip it into the water. You have to dip it into water to get it to cure. And I think it's a good idea before you dip it to go ahead and open it up, because it's easier to get this done first. And then we actually gather the sock ahead of time. This makes it all the easier when you're going to slide it onto the foot. And it's just like a sock. It has a seam. Red is for small, and it's positioned just like a toe seam of a regular sock. We dip it into room temperature water. We've got a plastic bag down on the exam chair. This is perfect for the STS sock because it doesn't stick to the sock. If you put a paper drape down, it's going to stick to your sock. So if you want to protect your chair, you can go ahead and put a plastic trash bag. That's a nice little pearl that we've learned over the years. And we're now going to put this sock on the patient. And we had the patient lift their foot just a little to help do this. You got plenty of time, particularly if the water is at room temperature. And this sock is going to come up to about mid-calf. So take your time and get it all pulled up onto the leg. Get all the redundancy out of it. And it's pretty tacky and sticky right here. We're going to first of all quickly take our special cutting scissors and we're going to cut a notch in the sock right at the front edge of the cutting tube, right at the base of the second toe. And we'll explain that later. And you might want to just dip your hands in a little water so you can begin smoothing the sock into the foot. Some people use a spray bottle, which is probably a little more convenient if you do this a lot. But the sock is tacky at first, but as you spray it down, the tackiness goes away. And basically what we're doing here is molding the sock into the anatomy. You're molding it into the leg, into the cutting tube, and most importantly, into the arch here. You don't want the sock to bowstring off the arch, or you're going to lose contour and lose effectiveness of the AFO. So take your time. You got plenty of time to do this. You're molding it in around the malleoli, back in the heel, the calcaneus, and definitely into the arch. You're not worried too much about positioning the foot yet. You can tell when the sock's beginning to cure. It's about the same length of time as plaster of Paris. So I can feel it starting to cure. I'm going to go ahead and position the foot now. So we just have the patient relax everything. And just like with your suspension cast, you're going to grab the 4th and 5th toes. You're going to feel for subtalar neutral, feeling the head of the talus, medial and lateral. Subtalar neutral. You're going to move in closer to the foot, and I'm going to just lift and load the mid-tarsal joint. I'm going to lock the mid-tarsal joint. The whole foot is positioned subtalar neutral, and make sure the patient's foot is relaxed, that they're not supinating the foot. And at this point, we're just going to hold this foot in this position until the plaster or the fiberglass dries. One final factor, a lot of these patients we cast for AFOs have a really elevated first metatarsal, part of forefoot supinatus. And at this point, we ask you to push down on the first metatarsal to reduce any supinatus. This particular patient here today doesn't have any supinatus, so when we push down, we see no motion. You'll see other patients with flat foot deformity. When you push down, there's quite a bit of reduction, which is a good thing. It gets the foot into a better position. So we're holding the foot here. We can feel that the sock is just about cured. And again, the curing time is about the same as plaster. The advantage of this sock over plaster is it's definitely neater and cleaner. It doesn't make a mess on the floor. You don't necessarily have to put a drape on the floor. It's cleaner for the patient as far as cleanup. In terms of accuracy, you probably need to spend a little more time molding this to make sure it's close to the anatomy of the foot. But overall, this captures the foot and the lower leg much better than a plaster cast. And it's much better for shipping in terms of its stability, shipping it out of the office. Okay, so we're pretty well cured here. Now, before we take this sock off, we have to mark the anatomy. And when we take a cast for an AFO brace or a foot orthotic, in terms of a AFO brace or the Ritchie brace, we want to mark the distal tip of the medial malleolus with a Sharpie pen, right there. And we want to mark the distal tip of the lateral malleolus with a Sharpie pen. And we prefer you help us at the lab mark the medial, the 5th MPJ and the 1st MPJ, just like you would for foot orthotics, so the lab knows where to place those balancing platforms. So medial malleolus tip, lateral malleolus tip, 5th MPJ, 1st MPJ. These are essential markings that must be on the cast before you ship it to the lab. Okay, so we're ready to remove the sock. In order to do so, we're going to cut right down the cutting channel, and that's made possible by simply taking this tube and pulling it out of the cast. Now notice the tube came out and the strip didn't because they were taped down in different locations. So we take the tube out, and now if you remember that little notch that we made earlier in the cast, we can start there and cut this way, or we can start this way and cut down. And this is a cutting scissor that is provided to remove the cast. You just snip down it. Another trick is STS gives you a little letter opener, and you can slide that in and continue cutting right down the middle. Okay, so that makes it a little easier. You have to cut it pretty far down, almost to the base of the toes, in order to get this off comfortably for the patient. And if you stay close to the cast, you're not going to hurt the patient, but you get up to about there. And then you just simply open it up like a little clamshell, and you just lift and slide it off. The baggie will come off with it, and you can just simply pull the baggie out at this point. And the cast is now ready to ship. Notice the markings are on the cast, medial and lateral, and we've got a good contour of the plantar surface of the foot. And this again can be used for a gauntlet brace or a standard Ritchie brace.